is the right one after you've read the question intelligently. And be careful when you read the questions, because some of them have traps in it. So you got to read the question. You can't say, oh, I know that, and jump at it. But then once you do that, if you think you know it, take your best shot. There are some studies to show that your first shot is probably the right one. However, if you don't know it, then try to eliminate answers that you pretty much know are wrong. And if you don't know that by your knowledge of emergency medicine, you can figure that out by things like questions that have always and never in it are usually wrong. Questions that are grammatically confusing or misspelled are usually wrong. And if you're still not sure, pick either B or C. Okay? Statistically, that's usually the right answer, if you're still not sure. But take your best shot, eliminate what you think are wrong, answer it, mark it, keep going. Okay, so let's practice, 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 so we can make it to Carnegie Hall, okay, and be able to afford the tickets. So I need volunteers, okay, because you hear me talk enough, right? I have Jewish mouth disease. I talk and talk and talk. So who wants to do the first and read it out loud in a nice, emotional, exciting voice? Go ahead.
25-year-old has severe pain in his right eye after being hit in it by a kiss last night. He has periorbital stenosis, intact POM, and no orbital tendons. Ophthalmoscope exam of the journal. The right pupil sluggish to reactive. Visual acuity is decreased in the right eye. The injection of limbus is shining a light into the left eye causes photophobia.
Okay, you got that? Here are your choices, and here's a picture.
C, traumatic iris.
I'm sorry?
C, traumatic iris.
Very, very good. Give that woman a prize. Very good. 2 prizes. Give her 2. You got 1 for braveness, being the first, and 1 for getting it right.
Yes.
Okay. So there's traumatic iritis. This is a classical presentation. Someone gets hit in the eye, seems okay, but over the next day they get worse and worse and worse. And they get eye pain, decreased vision in that eye, photophobic, not just in that eye, but classically if you shine the light in the other eye, it hurts them in the good eye, right? If you do a slit lamp, and they like to talk about that on the board, and someone who's very good at slit lamp is sitting back there, and you've seen this. Right, Mike? Right. And you'll see something called cells and flare. And if you can spend some time in Fast Track on Tuesdays, he will teach you how to use a slit lamp. Right, Mike?
I will.
Okay. Right? Treatment is cycloplegic agents. Okay, I like cyclopentolate, right? Cyclogel, the one I like 1%. You can use 1 to 2 drops every 8 hours, and it really gives them relief. Okay? You can also give them oral analgesics. I use Tylenol because I don't want them bleeding more. And if you're sure with a good slit lamp exam that is not a herpes infection or any other kind of infection, and there's no abrasion there, you can actually give topical steroid, but you got to be sure. Okay? And the one I like is Pred Forte. You're not sure? Just use the cycloplegics, use oral pain med, and have them see ophthalmology the next day if you can't get them to see them that day. They don't have to see them right away. Okay. Who wants to do the next one? Come on, some bravery here.
Which in head injured children has been shown to be most effective in reducing intracranial pressure? Hyperventilation, mannitol steroids, or neuromuscular paralysis.
Try to eliminate stuff you think would not be there and then take your best shot.
I'm gonna say non-neuromuscular paralysis. Wait, most.
Mannitol?
Yeah.
You were right.
Um,
Right? So even by elimination, hyperventilation used to be popular. There's some good studies to show it actually increases mortality. And the only recommendation to use hyperventilation, not normal good ventilation, is if you're desperate and they're dying in front of you and you have nothing else. Steroids, again and again, have not been shown to help traumatic head injuries at all. There are a lot of good studies on this. And neuromuscular paralysis is the way to go to intubate, but it in itself doesn't reduce intracranial pressure. In fact, some people feel using something, what's our favorite, succinylcholine, may actually increase pressure, right? But you have to knock them out and so that you can intubate and ventilate them adequately, and so you have to knock them out. But it won't in itself help pressure. And that's why you got to read carefully, because they want something that directly helps pressure. So always read these questions carefully, see what they want. Don't let them fool you, right? The next thing is mannitol. So Mannitol Bolus decreases intracranial pressure in acute traumatic brain injury, okay? Dose is 1 gram per kilo. Studies show it's better to give it as a bolus. It causes less dehydration, less changes in electrolytes and stuff like that, okay? And again, some recent studies show that hyperventilation worsens prognosis, different than we once thought.
Only in kids or in adults?
No, in everybody. Again, only use it in desperation. But you got to do good at ventilation. Keep the PCO2, 30 to 35. But don't bring them down like the old days to 20. Mike, you remember those old days, right?
I sure do.
I even remember those old days. Okay, so next. So who wants to volunteer?
This is easy as is.
There you go.
I do.
Okay, Roderick.
Which has been shown to decrease mortality in ARDS, low tidal volume mechanical ventilation.
Very, very good. Remember, this is ARDS complete, not just ARDS caused by infection, which is the most common cause, which antibiotics might help, but it's really the ones also caused by trauma and transfusion reactions and, and poor toxins as well as IVs. So the answer is low tidal volume mechanical ventilation. Here's a classical picture of ARDS. So low tidal volumes mechanical ventilation, what's recommended is starting with about 6 ml per kilogram and then reevaluating and see if you have to go up, okay, or down. Definition of ARDS, they want you to know. The newest definition is the PaO2 divided by the FiO2, it's less than 300. That is one of the criteria for ARDS. Bilateral infiltrates, okay, acute bilateral infiltrates. Remember, this is acute ARDS. And not caused by CHF, although the pulmonary artery pressure is usually over 18, but you don't want it to be caused by CHF, right? Other treatment besides cutting down the tidal volume, cutting down the shearing pressure, is PEEP, right? Keeping that plateau pressure on the ventilator less than 30. That decreases the shearing pressure. And then things like special oscillators and prone ventilation can actually increase survival if you have that option, right? And again, pneumonia is the most common cause of setting off ARDS, but it's not the only cause. Okay, who wants to try this and make me feel good? Someone who's done the ortho fast track rotation, maybe. All right, Ron.
Okay, so a man falls onto his outstretched hand. His x-ray is shown below, the best prescription. My guess is we're going to need an ortho consult
Here are your choices.
Apply long arm or splint to follow up in 1 week. Consult ortho for open reduction repair. Consult ortho, apply sling, follow up with ortho, perform closed reduction, ortho follow up in 1 week. So I would consult ortho and have them follow up with ortho because they're probably going to want to close reduce it. Well, okay, see, close reduce and ortho follow up in 1 week.
Okay, so
I can't see how complicated it is, but it's definitely. Yeah.
well, what do you see there? Again, what they may do here is not what the classical thing is to do. So remember, these go by classics, not what might be expedient or because they don't have an attending at night or other things, right? Or they're not making money if they come in at night like they would in most places. But describe it.
It looks like a radial fracture with an ulnar dislocation.
Okay. And what about the radial fracture? Is it
looks
dislocated itself?
Yeah, it's displaced and looks comminuted.
Okay, so anybody, Ron, you're anybody first.
Okay.
Do you know what this fracture is called? Especially in adults, it can be very complicated.
Montation or Galeazzi.
Galeazzi, this is Galeazzi's fracture. They love these eponyms, and they love the complications, and they love the classical best way of treating these. Okay? So, emergency ortho consult to repair the Galeazzo fractures B. In an adult especially, they should go to the OR. They may not here, but if you have someone who's going to make money off of them, they will do it. And that's what's recommended, the classical finding. All right? So it's a fracture dislocation of the distal radial ulnar joint. So the radius is fractured and dislocated itself, the bone, but also the joint that hooks up with the ulnar is broken, right? You want to see that again?
Yeah.
You see it? The radius. Here's the radius, right? I always know the radius because it's by the thumb. Here's the radius. You see it's fractured and displaced. And here's the ulnar. Ulnar's over here. These should be together. They're not anymore. Galeazzi's fracture. Or fracture dislocation. Okay? Okay. So, it's a fracture dislocation again of the distal radius, and it dislocates from the ulnar joint. Right? Delayed repair increases complications, especially if it's near the skin. It can break through. So if you see it tenting, that's a real emergency that you should make ortho come for, and you can heal. And because if it goes through, then it's an open fracture. You get a lot of malunion, infections, pain, disability, etc., etc., etc. So another question related to this. Okay, somebody else, because I don't want Ron to get too fat or diabetic or anything like that, because I like him. So someone else can get some free candy, right? What is this? Who said it first? Olu? Okay. Which Olu? Oh, the other Olu cut out, I think. There are two Olus. Good one. Give him 2 pieces of candy. That's better than my Uncle Martin joke. All right. All right. So this Montegian's fracture or dislocation. And in kids, you might get away with a closed reduction. Again, in adults, the classical is to go for an open reduction. And what do you see here, Olu? Olu number 1. Olu, the head priest of all the Olus. Okay? And my favorite Olu. Oh, he's one of my advisors. You can tell the other guy. So the ulnar is dislocated, and okay, the radius is fractured, and it's proximal, right? It's Monteggia's fracture. And like I said, in adults, it should go to the OR for fixed. In kids, sometimes they'll try a closed reduction, but there are different types we won't go into, okay? But the classical is really, you should fix it in the OR.
Both of those, Scalezi and Monteggia, need urgent OR repair? Both of those?
So in adults, yes, classical. They may not do it here, and that's all right. We can't take them to the OR, but classical teaching is yes. In kids, if it's not too bad, you might get away with closed reduction for a while at least. All right. Who wants to take the next one? Come on. You want to take that?
I'll take it, yeah. 7-year-old man presents with dyspnea and near syncope. Systolic crescendo, decrescendo murmur is heard on exam. Which treatment should be avoided?
Here are your choices.
So digitalis, lisinopril, nitroglycerin, or statins. So
Think about it.
Sounds like aortic stenosis maybe. So I would avoid a preload reducing agent. Like
And what's the preload here?
nitroglycerin.
Very, very smart. Thought it through. That's what you have to do when you're not sure, when it doesn't come to you like that, right? Very good. So nitroglycerin reduces preload, and that is contraindicated in symptomatic aortic stenosis. Because symptomatic aortic stenosis depends on the preload, right? You need that to help push your way through. And if you decrease preload, you can cause hypotension, leading to syncope, leading to congestive heart failure, leading to death, right? And once aortic stenosis gets symptomatic, you have about maybe 2 to 3 years to survive if you don't have some kind of surgical procedure done, right? And classical finding for aortic stenosis is a crescendo, decrescendo murmur. Usually it's loudest in the aortic area, which is around here, okay? And it radiates up to the neck. When it's very loud, sometimes you can hear it all over the place, especially at the apex as well, right? And it's a harsh murmur. Okay? I'm not good at this, so I couldn't make the sound, so you have to, you know, bear with my voice. And as it gets really bad, one of the clues is a narrow pulse pressure and something called pulsus parvis intardus, meaning the pulse is very slow rising and it comes late, right? Those are bad signs. Can I tell a story? At the risk of not finishing, well, I didn't intend to finish, but you know. But anyway, one story about it, why it's so dangerous. So when I was the director of the ED at Lincoln, one of the EKG techs come to me and says, could you read this EKG? In the EKG shows severe elevation, there are a lot of DPCs. They said, who is this? Where is this patient? I said, well, it's my friend, right? Who hadn't even registered yet. But, so I said, I got to see him. So they registered him quickly, and I saw him. And the story was, you know, he's a guy in his 50s. He had been in Spain, thought he was in good health, and was racing for a trolley in Spain, or a bus, or whatever you race for there. But anyway, he syncopized. They took him to one of the hospital EDs, and they told him it was probably vasovagal, but when he gets home, he should get it checked out. So anyway, when I listened to him, first I felt his pulse. His blood pressure was like 100/80. And I felt his pulse was very slow, kind of not bradycardic, but a slow rising pulse. And I listened to him, and he had a really loud aortic stenosis. I said, wow, right? Because there's what's called a deadly triad. You can get chest pain,
It's not funny.
I like Queens. I've been there. Okay. No aortic stenosis, because they love to give you a question on the board. The other one they love that's related to it, but a little different, is hypertrophic cardiomyopathy, where again they give you someone who's really exercising, usually a younger person, and then syncopized during the exercise. Okay. Okay, I also just want to look at that. I like this mnemonic. It's called CRAPS, because it's things that can kill you, very crappy things, right? So know the cause of syncope that can kill you. And those can be cardiac, like arrhythmias, right? And they love on the board to talk about things that put you at risk for arrhythmias, right? And we've had that kind of talk recently, but things like Borgata, and hypertrophic cardiomyopathy, and prolonged QT syndrome. Those are things you should know, okay? And then ruptured AAAs, aortic stenosis, pulmonary embolus, hemorrhage. Okay. All right, who's next? Who's going to help out an old Jewish man?
35-year-old farmer who's Honduras, presents with coffee from offices, fever, night sweats for 3 weeks. Vital signs is tachycardic, 22, about 100.6, which is 95%, and his chest actually shows.
Okay, here's your question. So you thought I was going to ask you what is the diagnosis, but they often will trick you. They're going to make the diagnosis, but then they'll give you another one to make sure you really know the subject, right? So you have to kind of do a double here. So here are your choices. Nobody said life was easy, as my dad used to tell me. Okay, but again, the most efficient. Not the one that you can make the quickest, but the most efficient. How efficient is getting a positive smear? Difficult. Right? So think about it. What else? Right. The skin test. Right? It's the PPD at the bottom there. Well, so actually, believe it or not, nowadays, if you can get it, we can't always get it here, but in places that can get it, it's actually C. Right? Again, you got to see what they're asking you. They're looking at an efficient test with being in some place like ABEM General. Right? So interferon, the gamma gamma release assay, which is quantiferon gold, as we know it as, right, is the most efficient test. If you have a place that runs it, they can do it for you the same day, and you can rapidly make the diagnosis of TB, which this is, right? Obviously, the best confirmatory test is a culture. That's going to take up to 2 months, right? Usually 6 weeks is the average. A chest x-ray on TB usually shows infiltrate and often pleural effusion. And even though classically we talk about, like in this x-ray, being in the upper lobes, especially immunosuppressed or in primary infection, it can be in any lobe, right? And pleural effusions are fairly common. You see a pleural effusion in someone with fever, you got to worry about TB, right? Treatment, at least to start with, before you know if there's resistance, always at least 4 drugs, right? Those are the most common drugs that are used nowadays. And you should know those drugs and know their side effects. Liver, color stains like your glasses and your contact lens if tears get on them. Messes up your vision, especially your color vision. Can mess up your liver, but also can give you gout. Okay, no TB, right? They love to put TB on this test, okay? Who wants to help me with that one?
30-year-old man presents with severe lower abdominal pain with nausea and fever for 1 day. For the past 2 weeks, he has had diarrhea with blood and mucus and anorexia with weight loss. He has abdominal distension, decreased bowel sounds, and severe left lower quadrant tenderness. X-ray shows dilation of the colon segment greater than 6 centimeters, loss of palpitations, and wall edema.
All right, so you should be thinking what you think this is and what might be the underlying cause. Okay. So this is something we don't see here much because I think of the ethnicity here. But if you go to Maimonides, you will see this more.
So it looks like a constricted distal bowel that's dilated proximal, toxic megacolon.
Very, very good. Very good thinking. Again, you probably haven't seen this, I don't know, but you figured it out, right? Toxic megacolon. And remember, the test is not made just for working in the South Bronx or just for working in central Brooklyn. It's made for the whole country. So they're gonna get things that we don't see here. Okay? So there's this toxic megacolon.
I would consider in my mind colorectal carcinoma, just because I would think maybe there's some sort of obstructing lesion that's causing it.
True, but usually you won't. Let me go back. Right. Usually you see when it obstructs what looks like an apple core lesion. It's constricting down, and you're not going to see some of those things like the wall edema and stuff, unless they're about to perforate. And they're not going to be this sick at the beginning until they perforate, which is a later finding. Okay? And then, so the diarrhea, the blood, the mucus, the anorexia, the weight loss in a 30-year-old, right? This was a 70-year-old maybe, but in a 30-year-old, you're thinking, again, risk factors. Who's at risk for what? And so always think about that. What is the risk? On the test is also different than real life in the sense that when they give you something, information, it's real. They tell you, that Maurice is an Eagle Scout and he's going, through the woods, and next day has an extremely itchy rash that's, weeping and forming blisters. Hey, the fact he was in the woods, poison ivy, right? Or, someone has fever and headache and myalgias and they live in Connecticut, right? Now they have one rash that looks like this, right? That's Lyme disease. They always will give you a little clue. They're not trying to give you the rare stuff or things. So when we say in Yiddish, in Magib Nem, if they give you something, you take it, right? It's for a reason. It's to help you out. Okay. Right? So this is toxic megacolon. It's probably due to ulcerative colitis. The age group is right. You can also see it with Crohn's. It's less common with Crohn's, usually not as acute. Suspected when suddenly they get increased pain and fever and tachycardia out of proportion to their dehydration and fever. They get severe diarrhea. And the x-ray helps with severe presentations of inflammatory bowel disease. Right? It won't help with mild to moderate. But when you're worried about a perforation, you're worried about toxic megacolon, instead of going with a CT, you can get a stat one and see. Okay? Here's how you treat it. And if nothing else works, then you may need a colectomy, especially if they perforate. Right? But you try to avoid that unless they perforate. If you look at this x-ray, look at it here. Look at this dilated. Know when they show you dilated loops, there are a few things that can do that. Know what a syncal valvulus looks like, right? Know what a sigmoid valvulus looks like, all that stuff, right? It's big dilated, but they look different, right? Know what they look like. It looks different than this, okay? And you can see here, these are called pseudopolyps. They're due to edema in the walls, and you get what's called thumbprinting in the walls. And here you can see the thumbprinting. Very classical if you see it. Again, as someone pointed out, the classical things don't always exist. So like I said before, vertical nystagmus is usually classical for something CNS. But you may see it from peripheral rarely. Right? This is very classical for toxic megacolon. And they love to ask some kind of question about inflammatory bowel disease. And sometimes it's this, sometimes it's extra GI stuff, like uveitis and rashes. Okay. Who wants to do the next one?
25-year-old presents with severe groin pain up in the hip and groin with a hockey puck. Playing
Where's the other Taylor? She loves to play hockey. We only have the original Taylor here today. Okay. Oh, and there's another. Oh, sorry. Yeah, we need one more Taylor.
What's your favorite?
That I'm not saying. All right, go ahead, Ben.
Complaining of severe scrotal pain and nausea. Scrotum is swollen. Ecchymotic. What is the most appropriate next step?
Okay.
Put it all back together. Yeah, foot humpies up together.
So again, you got to make the diagnosis in your head and then decide what's the best.
I think, so I'm worried for a ruptured vesicle.
Very good.
Probably D, even though I'd probably do B first.
So actually, we'll see.
I'd say D is what it is. B.
Right, so we're not sure yet, right? And it also depends on how bad the rupture is. If it goes beyond the thing there, I can't pronounce it. But, the albuginea. If it goes beyond that, then they may repair it. But usually you find it out. Now, if it's penetrating trauma, someone gets stabbed in the testicle, they just take you right to the OR. You don't need an ultrasound, right? Because as Bob Dylan said, you don't need to be a weatherman to know which way the wind blows. That's so obvious. But this is different. It's not always so obvious that you need to go to the OR right away. But you want to go within 72 hours, if not less. So you have some time, right? So this is severe scrotal pain. You were right. Think of ruptured testicle. They're usually in terrible pain when you see this. They may have ecchymoses there, they may have trouble urinating there. They don't want you to do a big exam on them unless you give them analgesia, right? And ultrasound actually is the best modality to look for testicles, or at testicles. So, here's fairly normal, right? It's heterotrophic stuff. Here is, you pronounce it for the Turcica, I can't even pronounce with my dyslexia. Albuginia is ruptured, there's stuff there, right? It's intact up here, it's not for this testicle. This is classical findings. This needs to go to the OR now. The longer you wait, beyond 72 hours, it goes from 90% salvage to about 50%. So you want to be aggressive now in pushing for it. Okay. I don't want to keep you guys late because we have a wonderful plug for board review. For those of you who should be in it, and you have to go unless you have another meeting. But we have a wonderful board review at 12:15. Dr. Z going to talk on neurological emergencies. Everyone's invited, even if you're not in board review. Okay. So, which of the following? Who wants to take it?
Which of the following after ingestion associated with delayed GI symptoms and liver failure? A, amine mushroom.
Okay. So why'd you say that? All right, so Mannitol Bolus gives delayed vomiting and diarrhea followed by hepatic failure, right? Now again, it's not 100%, but especially Amanita, which is the most toxic mushroom, Playard being one of them, and there are a few others, they actually the greatest number of deadly poisonings when you add all the amanitas together of any mushroom, right? And it characterized that the vomiting and diarrhea is delayed. It's more than 6 hours. Usually, not always, usually with non-toxic mushrooms, they vomit right away, right? Usually. So, but delayed vomiting, you got to worry because they're at high risk for hepatic failure and in rare cases even hepatic renal syndrome. So, very deadly mushroom, okay? And there's a picture of it. Anybody knows what other name it's called? Death cap, the devil's cap, right? That's Amanita Bolus. And there's an old saying. There are bold mushroom hunters, and there are old mushroom hunters, but there are no old bold mushroom hunters. You have to know what you're doing. Okay. You guys don't like my jokes. And you don't like my all right. So, one of the other choices was oleander. And oleander, lily of the valley, foxglove, and there are others. Right? Those have digitalis glycosides in them. Right? Not exact, like digoxin type. And so with those, you get almost pretty early on, if you eat a lot of those, you'll get vomiting and diarrhea, you'll get hyperkalemia, and you'll get death from an arrhythmia. What arrhythmia is that? And that's how it kills you. That's VTAC. So it kills you with VTAC or VFib. Okay? Very good. You can give her one even though she's from Queens. So you shouldn't feel bad, Sarah. The story behind my animosity toward Queens is that when I was young, I went out with a girl in Queens, and she dubbed me. Oh. Right? So nothing toward you. All right.
Well, you shouldn't have taken her to Queens.
No, I met her and she lived in Queens. All right. So, this will be the last one, real quick, because we're running out of time. Okay? Who wants to take this? Walking on the beach. This is where MacGyver would like to be. So MacGyver, this is all yours. You love this walking on the beach stuff.
Foot pain after walking in shallow water. She felt a prick and then severe foot pain. Exam shows a puncture wound on the dorsal of the foot. There's swelling or erythema, which is the appropriate treatment. You're there.
Well, you could piss on it, yeah. It might help. Some things. Very good. Here are your choices. Kissing is not one of them. Although people have been known to do that. Yeah, hot water, not hot enough to scald, but that works for this. So this hot water immersion is the initial treatment for stingray envenomation. May also help these other envenomations, right? You got to be careful with jellyfish. Some of them will help, but some of them will get worse, especially what's called the Cynodera family, right? Because then fresh water may release, if you use fresh water, may release the nematocytes, especially the ones in America, not so much in the ones in the Pacific. So there, your safest is to use seawater until you can get acetic acid. Acetic acid may help jellyfish bites. Not all, but some. And, okay, this is a stingray. And why this is a stingray envenomation is they're in the ground, they don't want to bother anybody, you step on them, and the stinger comes here, stings you on the foot, there's not much inflammation, but there's venom put in, and it hurts like hell. And if it's a big stingray and it gets you in a vital place, it can kill you. I don't know if you guys knew about the crocodile hunter, right? After all this big 30-feet crocodiles and all kinds of things and boa constrictors and everything that he fought against, he actually got killed by a ray that he was playing around with, a big one, and it stuck him in the chest and went right into his ventricle, right? And that's how he died. Huh? Oh, and then he bled to death, right? Yeah. Okay. So I knew I wouldn't finish. So some take-home points. Study. Practice doing questions, right? You want to get certified. You don't have to go to Carnegie Hall unless they give the computer test in Carnegie Hall, but you need to get certified, okay? And again, I love the new Hair 9. And if you want to get it, it pays, but if you're thinking that, I can't afford it, I don't want to get it, don't say I said so, but you can speak to a guy who helps me, who has a beard and is EMIM boarded, and who's one of the nicest people you'll ever meet in the universe. But I'm not saying who he is. Use test-taking techniques to help you. Study the things I put down on that email I sent out that will be on it, but especially now with a week left, I would do questions and use it like my textbook, right? Read the answers. Because a lot of times, even though that question might not be on there, something in the answer is on there, right? And then good luck and live long and prosper. I can't believe it. Can anybody do that? Oh, that's great. That's better. All right.